Thanks so much, Dr. Appia, for the introduction, and to Dr. Woodruff for the invitation to present here. It's just really my favorite meeting to participate in, of all meetings. And it's also great to be back at Northwestern, where I trained and spent so much of my career. With that being said, bear with me because I want to cover a lot of ground this morning, and so I hope that if you'll tolerate my quick pace at the break, if there are any questions or further things I can elaborate on in a more relaxed pace, I'm happy to do that at the time. So getting started, the topic of breast cancer incidence stays rather stable every time that I introduce it. It's about 250,000 new cases every year, about 63,000 DCIS cases. That's the stage 0 breast cancer, for which chemotherapy is typically not indicated, though surgery and radiation and anti-hormonal therapy are typically implemented. And these are actually the 2017 numbers, so these have already come out for the breast cancer facts and figures from the American Cancer Society. The mean age of diagnosis of breast cancer in the United States is 62, which is a little bit higher actually than most other countries that are looking at these types of numbers. But I want to talk specifically about our patient population today, and that's young breast cancer patients, which accounts for about 7% of new cases every year. And these are patients under 40. There is even an additional cohort, which I think comes to close to 10% more of patients between 40 and 45. Pregnancy-related breast cancer is increasing as childbearing is delayed, and this is a societal normative change that I think we've all appreciated through the discussions that have occurred over the last few days. Of all new pregnancies in the United States, 1 in 3,000 will be a patient who also has breast cancer, which I think seems like an incredibly high number to me, but it is the data that I'm familiar with. These cases are typically occurring between women ages 32 to 38. Today, I'm going to really just try to provide you with some guidelines about how we manage breast cancer before pregnancy, and that's fertility preservation, much of which we've talked about through the meeting. And then I'm going to discuss breast cancer during pregnancy, and I'm going to break it down by trimester in terms of what the options are for us to be able to implement and to give a framework in terms of how we manage this problem based on when the patient is presenting during their pregnancy. And then talk about patients with BRCA mutations, for which being at a referral center, in which many of you I think also are probably experiencing, is that we see a lot of patients with mutations, and now not just BRCA mutations, but a host of other mutations as we go to a 22 gene panel. And so there are different issues that are associated with different mutations, and now we have to actually all become expert in these different kinds of mutations as we advance in our understanding of genetics and genetically associated disease. And then I'm going to talk a bit about tamoxifen initiation and continuation in light of the new New England Journal paper that came out about extended endocrine therapy just 4 days ago. So with this, the global view of what happens when I see a new patient with breast cancer, typically as a surgeon, I'm the first interface that the patient is having with medicine. And what I would intend to do is to discuss the patient's diagnosis, discuss the guidelines for care, and at the same time, I'm trying to feel out the patient and what their goals are and what they're going to be willing to accept out of the things that I'm going to make recommendations for. And then we talk about considerations for pregnancy, future fertility, and we try to discuss this upfront at the first visit that the patient has when talking about breast cancer. But I think that the thing that I've learned over now 12 years of practice is that no matter how much I have tried to look at each patient as a unique entity and not bring any bias into my discussion with the patient, I think that these issues are just inherent at times to how we see our patients, and we have to really fight through some of the more sort of consistent assumptions we may have about a patient based on what they present with when they come to our office. And so really can't assume issues about fertility preservation predicated on patient age, whether or not they already have a child, whether or not they're married, or what their orientation may be. and an assumption also on treatment, which I think at times can be very difficult. You may say, look at a patient who's young and has small volume disease and realize ultimately that they actually have a very different pathology once they're through surgery. So I think you have to take it very seriously and I think dogmatically that any new patient that comes to see you needs an early referral, and you really can't be the person, the clinician that makes that decision. It just has to be a set part of your practice that your patient's going to get referred for fertility preservation. So with that, again, as I stress, pregnancy and childbearing is being deferred. More frequently, women with breast cancer are desiring a pregnancy after they recover from their breast cancer. But now I'm going to talk about some information that I feel is really why we're all here today. There's a significant place where we can have an impact on patient care. So last year, a paper came out from the Cleveland Clinic citing just about 26% of breast cancer patients being offered or having a discussion about fertility preservation over a span from 2006 to 2014. They showed about a 7% pregnancy rate from that cohort about 3 years post-breast cancer treatment. And then this Canadian study, a 36% of Canadian breast surgeons saying they rarely or never discussed fertility, but 51% feeling that the fertility referral was really not their responsibility. And so this is why I think if you feel that we reiterate some of the things that we discussed here during this meeting, it's just to try to say that there's still a lot that we need to do to change. And I'm just going to quickly show you this data that came from Northwestern that showed what the impact of having programmatic implementation can be. And so there's a cohort in red that's from 2004, 2006, before there was a formal oncofertility program at this institution. And then the data in blue from 2007 to 2012 when we established a formal navigation program and became a group that met in a multidisciplinary format on a regular basis to talk about patients who have fertility threatening issues. And you can see how significantly impactful this was in terms of documenting discussions, having patients be offered fertility preservation appointments, actually getting an appointment, and then having a procedure. With that, though, we still didn't reach 40%. And so, again, I just stress the fact that there is a lot you can do, and there's a lot you can do starting like tomorrow to try to improve the impact of the reach you'll have on patients who are contending with these issues. So now just to talk a little bit about fertility preservation. As we understand, chemotherapy can contribute or cause infertility. Tamoxifen is now being recommended up to 10 years, which I'm going to talk a little bit more about in a few minutes. We know the options, oocyte and embryo banking, to be the real standards now for ovarian tissue cryopreservation on a research basis, but it's being more widely implemented around sites around the country as more protocols are being accepted at different centers. But there's also issues with surgical treatments, not just for breast cancer, but of course for patients who are undergoing colorectal surgery and definitely GYN malignancies that will have an impact on fertility. And radiation therapy, too, can have ramifications on future pregnancy. And specifically, as I think about it for breast cancer, breastfeeding and reconstructive options. So again, timing is critical. The standard treatment sequence for operative breast cancer, which is the majority of cases that I would see, upwards of 80% of the patients presenting every year, which should be operable, would be surgery, chemotherapy, radiation, and then potentially tamoxifen for the 70% of our patients who are hormone receptor positive out of the cohort of new patients diagnosed every year. And incorporating fertility preservation into this, now that we're really starting to implement random start protocols, potentially there could be an oocyte retrieval before surgery, and then potentially an oocyte retrieval after surgery, then implementation of chemotherapy, radiation, and tamoxifen. So this would be one way to think about how you might be able to get a patient with breast cancer through fertility preservation. If neoadjuvant therapy is going to be needed, and these are for patients who have inoperable breast cancer or presentation, locally advanced disease, or have a certain breast cancer subtype for which it's been demonstrated that neoadjuvant therapy would be the appropriate way to proceed. Specifically, what I'm thinking about are patients who have the HER2 subtype that is larger, like a stage 2 HER2 subtype breast cancer. We're now suggesting that treatment before chemotherapy before surgery is actually optimal. And so for those patients, you're really needing to engage your medical oncologist in an urgent way, so that you can't say that this is a patient that they can just add into their schedule 5 weeks from the time that you meet them. They need to be seen that week so that a plan is put into place, and then there can be a plan for retrieval before they initiate neoadjuvant chemotherapy. So in this instance, it would be fertility preservation discussion, oocyte retrieval, initiation of neoadjuvant chemotherapy, surgery, radiation, and then potentially tamoxifen if the patient's ER positive. So in thinking about fertility preservation, these are just some rough guidelines that I'm offering to you about how you would manage a patient with breast cancer coming to your office who was not pregnant but was interested in fertility preservation. Early referral, integrated multidisciplinary care, I really do believe is the best way we manage our patients, not just in the setting of fertility preservation, but in all of cancer management, because it provides us with the best way to talk about problems as a group. And really, if there is ever a time where I may forget to mention something about fertility preservation with a young patient, I have a room filled with other people who are caring for this patient who will remember and also help me to get patients placed onto trials and to really do the best they can to expedite, to facilitate patient care. In terms of breast cancer during pregnancy, admittedly, I have to say the treatment of breast cancer is complicated. There really is no one correct plan we can implement for any specific patient, but I can't really imagine a circumstance I deal with that is more complicated than the pregnant breast cancer patient. And this is just a very challenging set of circumstances to contend with when you see a young pregnant patient come through the door who's now in a feeling like they are facing their mortality at the same time as they're also thinking about their unborn child. So these patients really may need additional time and consultation to process their treatment decisions. And I think you may need to see the patient, talk to them about what their options may be, have them see a medical oncologist, and then see them back within the same week so that you allow them to really marinate on the ideas that you've offered to them in terms of what they will potentially be up against, and then bring them back so that you have a chance then to drill down on what it would be that they're going to have to contend with. Unfortunately, breast cancer detected during pregnancy is often more advanced because this is not a population that's typically being screened. The most common mode of detection for these patients is a palpable finding with or without axillary involvement. And I think it's important also that we have to stay up on the literature, because management options can really be very fluid in terms of advances in neonatal care and sort of this moving target in the determination of fetal viability that can be different from institution to institution, predicated on practice patterns. So essentially, we have to balance the health of the mother in terms of need for treatment with the health and well-being of the fetus, which is the impact of the treatment. And these priorities, unfortunately, in terms of the treatments we recommend, often conflict. Surgery, chemotherapy, radiation, and anti-hormonal therapy all have an impact on the developing fetus to varying degrees, largely based on the time frame during exposure. So really, I think that there has been a tremendous advance, and I want to just stress to this group that we give chemotherapy to our patients in the 2nd and 3rd trimesters. I think sometimes this news is just a surprise to people when they hear it, but this has been actually happening since original studies largely done at MD Anderson in 1992. So it may feel like something you didn't know or weren't familiar with, but it's been happening for several years at this point. While there are no randomized trials, I'm reassured to tell you that the youngest patients who experienced these exposures back in the 90s have moved on and reached all their developmental milestones. The kids that were born have done well. They've moved on, and they have matured and advanced and have been incredibly healthy. But we do make a lot of considerations based on diagnostic subtype, trimester, the stage of the cancer, the hormone receptor status, to determine the best, safest approach for any patient that presents. And then we really, as I say, talk about this on a trimester basis. So jumping into 1st trimester, really this is sort of a more binary time frame for patients who are diagnosed. Surgery is associated with a risk of miscarriage due to exposures and the stress of surgery. We don't implement fetal monitoring, as this is below the level of viability for the fetus, but we would check a fetal heart rate before and after surgery. Sentinel node biopsy safety is controversial, and I can just say that as a blanket statement for all trimesters, though we do implement it not with blue dye, which is a decisive teratogen, and that's one of the things we implement very routinely for the treatment of breast cancer, the surgical management. So we actually use technetium sulfur colloid, a radioactive colloid, and that has been demonstrated to actually not have any long-standing, lasting impact or effect in the body, as it degrades rather rapidly. In terms of surgery, mastectomy is the standard. Is reconstruction appropriate? It's likely no. At this point, you're trying to get your patient on and off the table as quickly as possible. Many patients want lumpectomy, but this is not typically offered as the primary surgical option. Workup is very compromised during this time to really understand the extent of disease, but also for a patient who should, if they're having lumpectomy, initiate either chemotherapy or adjuvant radiation therapy in a matter of 28 days. Neither of those things would be appropriate during first trimester, so it's really taking the patient out of the box for lumpectomy if they're diagnosed in the first trimester. So again, unfortunately, there's often an associated delay in treatment given the restricted limits on treatment during first trimester. So surgery, yes. Chemotherapy, no. Radiation, no. Tamoxifen, no. So I think if adjuvant therapy is to follow, you can imagine, as I just described, radiation would be delayed, chemotherapy would be delayed, and tamoxifen would be delayed. So this is a difficult time. So management is feasible in selected cases. I think specifically for patients with DCIS, and mastectomy is often treatment for cure in that set of circumstances for the patients with stage 0 disease. If patients are going to have surgery in the first trimester, they will have to wait to the second trimester in organogenesis to initiate chemotherapy. There are significant concerns about the long-standing exposures to high levels of estrogen for patients who are ER positive during pregnancy, and could this fuel the growth of the tumor? And I have to be honest, this is definitely one of the times where the onus is upon you to discuss potential termination as a situation for the patient who's diagnosed in the first trimester, but this has significant ramifications, psychological, spiritual, and just a great, really existential angst of considering ending a pregnancy, but then having the patient talk about fertility preservation. And so just really one of these great existential problems we deal with. Moving on into second trimester, though, in terms of where the options now expand, I think I feel like I relax a little bit more when a patient comes in the second trimester, because now the options open up. Surgery certainly is an option as organogenesis has largely taken place. This is a time where we feel comfortable offering chemotherapy. Typically, that's in the form of adriamycin Cytoxan. Recently, I had a patient present to me who'd been treated at another hospital in my state. The medical oncologist wanted to give the patient a taxane. A different medical oncologist on the West Coast, who was a family member, heard this and got incredibly upset and told the patient she had to leave her practice in where she'd been treated and where her high-risk OB was actually also somebody that she had a great relationship with, to come to our institution because they didn't think that she would see a taxane at our institution. And it created a lot of anxiety and stress for this patient at a very vulnerable time. By this point, she was in her third trimester. And so I think that there's still a lot that we're working out in terms of implementation of all regimens during chemotherapy. But for right now, many medical oncologists would not want to give a taxane during chemotherapy during pregnancy, and I can understand. I think at this point in time in the literature, there are just about 40 case reports of all cancer subtypes of patients receiving a taxane. So stay tuned. I think that news is evolving. Certainly no Herceptin, no trastuzumab during pregnancy. This is a significant teratogen. No radiation, no tamoxifen. There is a risk of miscarriage associated with the diagnostic timing during the second trimester. We do implement fetal monitoring during the time of surgery for patients in the second trimester. Again, sentinel node biopsy is implemented, though not with blue dye. If you're going to perform a mastectomy, I really, at this point in time, also again suggest that reconstruction is not appropriate. And there's really no role for any abdominal tissue-based flap reconstruction. Somebody did ask me that question once, and I just want to summarily say that that's not appropriate. So again, in terms of how we implement, or the options to implement care for patients in the second trimester, it would potentially be surgery, chemotherapy, delivery, and then potentially implementing radiation, or chemotherapy, surgery, delivery, or surgery, delivery, chemotherapy, radiation. And that would actually be, I would say, putting the chemotherapy off to the longest time. And so again, mastectomy is the primary surgical option. The issue of being BRCA positive at this time often does come up. I'm going to speak about that in just a few minutes. I really do not recommend any prophylactic surgery or any surgery that is not indicated during the time of pregnancy other than to address the cancer itself. Moving into the third trimester, now I think that you can really try to begin to think about your patient like you would think about a non-pregnant patient. By 34 to 35 weeks, the fetal lung maturity is largely evolved, and early delivery is an option. Interestingly, I just saw a paper that came out, I think just a few weeks ago, that actually delineated that in terms of quality, life quality years, for patients who are diagnosed in stage 1 or stage 2 breast cancer, third trimester delivery at 36 weeks was a really thought to be an appropriate sort of balance of health of the mother, health of the fetus. But for patients diagnosed at stages 3 and unfortunately stage 4, which is just so hard to consider, but that being said, you would really push for earliest delivery at 31 weeks, and that was an interesting study that I believe came out of the University of Oregon. Just to give you some understanding about how much we're trying to really think about the most appropriate way to manage the patient in the third trimester, we're really thinking about the actual long-term outcomes, disease-free outcomes for the mom based on a matter of just a few weeks, but I think that they can be important. And so with that in mind, I would say that this is a diagnostic time with the least compromise to fetal well-being. Preterm delivery remains somewhat of a risk. It is a really critical time to have a very nice relationship with your high-risk OB team standing by to help you during surgery, and then also after surgery, and if you're going to continue to implement chemotherapy, to have a very good discussion about when delivery is expected, to try to avoid a time of nadir so that you're not delivering through a nadir period in the chemotherapy cycle. The potential for treatment delay should be minimal. The surgical options now expand to also include lumpectomy, because the expectation would be that the patient would deliver and then go through what would consider to be a relatively standard additional adjuvant treatment regimen with chemotherapy and then radiation. So in general, in this trimester, there should be little compromise related to breast cancer care and the initiation of therapy. And this slide just summarizes all the trimesters that I've talked about in a colorful pictorial way so that you can think about how to manage your patient in terms of surgery, chemotherapy, and radiation and endocrine treatment through the trimesters. Just to basically underscore again, first and second trimester for surgery, really only mastectomy. Chemotherapy becomes a possibility in the second trimester. Outcomes are very reassuring. And in the third trimester, really expanded options to include what would really be considered for the non-pregnant patient. Now just talking about BRCA mutations. Again, I see a relatively large population of mutation carriers in my practice. Approximately 20% of young patients will have a mutation, a BRCA mutation or another type of mutation. This mutation really confers a very significantly increased risk for breast cancer, 40 to 80%, and 20 to 60% for ovarian cancer. And this risk accelerates for ovarian cancer as patients reach near the age of 40. The timing of cancer diagnosis is unpredictable. And I contend with this in my practice all the time. A patient who says to me, I'm a BRCA1 mutation carrier, but I'd really like to delay my surgery till I'm 50 because that's when my mom had her cancer, and I'm really a lot like my mom, and so I think I should just have my surgery when my mom was diagnosed with her cancer. That's my plan. And I have to say, really, that's not my plan. And I can't really tell a patient that they and their penetrance will mirror anyone else in their family. And so it becomes a very careful discussion about trying to implement or to plan for a surgery really at the earliest possible time when the patient is ready to move forward. And so I just want to stress to you again, we can do a lot of modeling about familial penetrance, but it's just not based on anything that would be considered substantive in terms of actual medical knowledge. In terms of the BRCA mutation as it relates to pregnancy, it's focused again on the timing of risk-reducing mastectomy and salpingo-oophorectomy. For BSO, it's typically recommended that you would complete childbearing, the patient would complete childbearing, and then at the same time, though, for patients with early penetrance ovarian cancer in their family, they may feel an intensely stress to proceed with a BSO, so they can go through a stim and cryopreserve oocytes or embryos and have a BSO. And so some of this, then proceeds to a discussion about surrogacy. I know we've talked about this a little bit at the conference already. But I think the thing I want to drive home about the option for this patient that is oftentimes not discussed or understood is that pre-implantation genetic diagnosis is a tremendous opportunity for these patients should they choose to proceed. And so this would be the chance for the BRCA mutation carrier to have embryos created and then go through PGD to determine their embryos, if their embryos have the mutation. And then at least the patient has the option not to proceed with an embryo that has the mutation as they move forward with their family planning. And I just cannot emphasize enough to you how I present at national meetings. I present this information to my patients, and people would say, either in the audience at a meeting or my own patients would say, when will this be possible? And I say, it is possible right now, right? It's been possible for years, but I think we have to do better at making this available. It's, of course, very costly, but at the very least, you want to afford your patients the knowledge that this is possible today. In terms of what the implications of mastectomy after surgery, so mastectomy after surgery for these patients, nursing would not be an option if they have a subsequent pregnancy, and that can be a very weighty issue for many patients as they consider timing. And so in terms of why I would favor a mastectomy before a pregnancy is that this decreases the need for screening during pregnancy. It decreases the likelihood that the patient will have a palpable finding during pregnancy that generates a lot of anxiety for the patient, imaging and biopsy, and a difficulty in terms of knowing how to manage these findings. And it also significantly decreases the risk that the patient will have a breast cancer diagnosed during pregnancy. There are some data available that show that the patient has a higher degree of penetrance, and specifically for BRCA2 mutation carriers in the few years postpartum. And so the more you can do to reduce that risk for the patient, obviously, the more I would want to sort of encourage the patient to consider this. A con is significant, though, and that's the loss of the capacity to nurse, which is very difficult for many patients to accept. And so to summarize my thoughts about this, really young patients with breast cancer and patients with BRCA mutations have a complex relationship with fertility and pregnancy. And again, multidisciplinary care, I really feel, is the key to expediting care and affording the patient the greatest amount of options to determine how they feel most comfortable proceeding. The primary treating oncologist, and that's surgical oncologist or medical oncologist, really have the responsibility to take the initiative to get their patients options and to talk with them about what their options are. We know these guidelines from ASCO, ASRM, and NCCN, and many other governing bodies are in place, but we still have a lot to do to implement those guidelines, and I really feel like we all here today have a lot of capacity to make change. So the last thing I want to briefly talk about is the impact of fertility concerns on tamoxifen and initiation and persistence. And interestingly, I've had a lot of people come up to me in the last few days and who have read the New England Journal article that recently was published by Dan Hayes, a colleague of mine at the University of Michigan, looking at the 20-year risks of breast cancer recurrence after stopping endocrine therapy at 5 years. And so this is a really Herculean effort that ensued to publish this data. And the reason why the data was culled is because a few years ago, some information started coming out of Europe and then the United States implying that 5 years of anti-hormonal therapy, which again would impact about 70% of our breast cancer patients, 5 years is not enough. 10 years is really the new best treatment. But tamoxifen is a teratogen, and that would make for a patient 10 years of time where they would not really be able to consider any fertility options. And so with that, the question becomes, who would most need to have a total of 10 years of treatment? And so a meta-analysis of 88 trials, over 62,000 women with ER-positive invasive disease were looked at after the 5-year interval of time of tamoxifen therapy to then say, subsequent to their 5 years of scheduled tamoxifen, what happened to them from 5 to 20 years of follow-up. And unfortunately, what was determined is that recurrence did occur steadily throughout the 5 to 20-year study period, largely correlated to the patient's stage and tumor grade. And so the risk, again, is correlated to favorable grade being as low as 13% with, this is T1 N0 lesions, to as high as 41% for patients with high-grade node-positive disease, more than 4 nodes positive. And so I think having this study really fuels, again, the need for us to have at the ready options for our patients who are going to require 10 years of tamoxifen, and that's going to be most of our young patients. And so to address this issue, we actually did a study at Northwestern looking at over 500 patients to really understand how best to implement tamoxifen into the plan for potential pregnancy. And I just again want to stress the reason why we think a lot about tamoxifen is because it's incredibly important and can be life-saving. 5 years of tamoxifen in the 55 meta-analysis of the 55 clinical trials that looked at this drug resulted in a 47% reduction in annual recurrence risk, a 26% reduction in annual mortality, and a 47% reduction in contralateral breast cancer. So we talk about this drug because it really matters for patients in terms of their disease-free survival over their lifetime. And we also talk about it because for our youngest patients, were found to have the lowest rate of long-term implementation of the drug. And we did look at several patient, provider, and drug factors to try to understand why this was the case. And I want to, again, stress to you, it was just a very comprehensive look at demographic factors when the patient hit the door, but also reasons why the patient then didn't initiate or didn't continue with the drug once tamoxifen was recommended to them. And what we determined for patients who didn't initiate is that fertility was a significant factor in why they didn't initiate, and also a significant reason why they didn't initiate once it was recommended. And for patients who discontinued early, again, fertility was a significant factor in why they stopped taking the drug and was a significant reason, other than side effects for both initiation and continuation, fertility concerns, the second most important reason why patients didn't continue with the drug. And so this is a tremendous opportunity for us to talk about how to then say to ourselves as practitioners, the optimal implementation would be 10 years, but our patients are voting with their feet. They are walking out of our offices, and they are not taking the drug if we suggest to them that they have to take 10 years of interrupted therapy. So we need to go to the data and say, what does the data show us about some type of compromise that we can make that would be reasonably supportive to allow us to make a plan that would implement the patient's objectives for survivorship and us as practitioners, the objectives for treatment. And there's some good data from the early breast cancer clinical Trialist Collaborative, as well as a French study and the Wisconsin tamoxifen study showing that the patients who were in control arms of the tamoxifen studies, the placebo group, who then crossed over even after 2 to 8 years on placebo or not having seen the drug, still had a significant benefit when they initiated. So as a result of that, we really did feel that there was the potential for a tailored delay in tamoxifen therapy to allow time for pregnancy or potentially a hiatus. And happily, the International Breast Cancer Study Group agrees with us, and they established the positive trial. This is a trial that is accruing worldwide. It was activated in July of 2014. Ann Partridge, I believe, is the national PI here in the United States, with many centers opening this trial around the country and around the world. I was just in Asia earlier this week, and I was with the Korean national PI for the positive trial. trial. So again, I want to impress upon you how widely this is being implemented around the world, but really asking patients post completion of their adjuvant therapy for breast cancer to stay on anti-hormonal therapy of some form for 18 to 30 months, to then go through a 3-month window of washout of the tamoxifen metabolites, and then attempt a pregnancy and nurse for 2 years, and then go back on tamoxifen for a total of 10 years. And I think this is really the trial we were all hoping for to see, with a prospective capacity to tell us about the safety of either a delay in initiation, and in this instance, a hiatus from drug treatment. So I look forward to those results, and I really believe the intensity around the trial is so high that we are going to be getting information at intervals before the trial is finished accruing to help guide our decision making. So to conclude, young survivors are a unique patient population. They contend with many different survivorship issues before pregnancy, during pregnancy, and when they're at great risk for the development of breast cancer. There are guidelines in place to recommend earliest referral to our patients to fertility specialists, but we can improve upon this, and I think everybody here is going to have a significant impact on that. But I think the responsibility really rests on the shoulders of oncologists to understand how important they are in getting their patients to at least have informed consent for fertility preservation. And so with that, I want to thank all of you for your attention this morning to a lot of this diverse information, and of course Dr. Woodruff, my colleague at Mount Sinai, Lisa Port, and Molly Morovic, who's here, who sees all my patients up at Michigan, and who I'm so grateful to. So thank you so much.
Thank you, Dr. Jeruss. I would like to open the floor to any questions that anyone may have.
Marvin Maastricht, MD, Anderson Cancer Center. I'm a researcher, not a clinician, but we did a study in mice where on day 10.5 and 11.5, which is mid-pregnancy, we exposed them to cyclophosphamide. One thing we got was a high incidence of testicular cancer. The pups were born, had normal birth weight, so they were healthy pups, but testicular sperm counts and weights were markedly down, and ovarian follicle counts were even more reduced. So we discussed it with the medical oncologist, and we'd hoped to get something going, but nothing ever came of it. But my understanding is that their children that they're following are healthy in other respects, but they have not studied their future reproductive potential.
Yeah, there's nothing in the literature that supports that these patients have reproductive challenges, but I think you draw attention to an issue that may need to be looked at more carefully. Yeah.
Hi, thanks so much for this talk. I'm Michelle McGowan from Cincinnati Children Ethics Center. I had a question about the BRCA 1 and 2 positive patients that you might recommend PGD for. And my question pertains to the success rates of PGD, which are historically lower than those associated with a typical approach with IVF, regardless of whether the patient has been diagnosed with infertility or is seeking PGD for a known genetic mutation such as BRCA 1 and 2. So how do you balance the benefits and risks of delaying an oophorectomy in order to have children naturally against the potential benefits and risks of known lower success rates of live birth with PGD?
Well, I think at this point, what I want to do most is make sure that patients understand that they have a chance to hear what's possible for them, and then balance what makes the most sense in terms of their sort of personal religion and agenda. And I have all kinds of things happen to me when I talk about these issues with my patients. And I was talking to Dr. Koutafaris about this yesterday. I had a patient come to see me, a young patient who was trying to decide when to proceed with mastectomies. And I mentioned to her that I had colleagues that could also talk with her about PGD and REI options if she wanted to consider that. And when she came back to see me, and I mentioned that I didn't see she'd proceeded with my referral to Dr. Morovic, she said, well, I decided that you're trying to play God on me, and I don't want you to do that. And I said, well, I will. That was not my intention, So I tell you this rather striking story primarily to mention that my intention is only to say this is the state of the science, and this is where it's evolved. But I am not there to tell the patient how I think they should proceed. But I don't want a patient to come back to me and say, I now have a child who's a BRCA mutation carrier, and there was a technology available that I could have engaged with, and no one told me. So I don't feel I can really address your question directly, nor do I mean to be tangential. I really just want to be the person who provides them with informed consent.
Great, thanks.
Sure.
Hi, thank you for your presentation. I'm Dr. Kataoka. I'm breast surgeon from Japan.
Oh, nice to meet you.
Nowadays, we are trying to discuss with the patient about fertility preservation. But now I have a question about when is the best timing for become pregnancy? Before pregnancy, do you check without recurrence or no metastasis?
I think that's just a terrific question. And interestingly, another paper also just came out in the last few weeks that addresses that issue on a large population-based manner. And it's actually a European study. And it demonstrated reassuringly that there was no time frame that was better than another time frame. 6 months, 2 years, longer, 5 years to wait, nor was there any discrepancy between ER positive and ER negative breast cancers in terms of risk of distant recurrence or overall survival. The outcomes were all largely similar. And so this was the largest retrospective cohort study that's been done to date. And this just came out, I think, in the last week or two, and I'm happy to send it to you. But and I think it's a study that stems from the Netherlands. But I think that one of the conclusions from that paper was that we need to try to eliminate some of the inherent biases we have about telling patients they need to wait 2 years, because we just don't have data that supports that information. And I've said this before, and I say it again in this room to those of you who've heard me say this before. Our problem is really emphasized by the fact that we're not going to be doing a prospective randomized trial on our survivors to randomize one group to no baby and another group to baby. And because of that, we can't really say that we'll ever have the information to perfectly address your question, but I do believe that I have to speak openly with my patients. I would prefer them to be on tamoxifen for some amount of time, but that is just my bias. That reflects the positive trial, and I stand by the design of that trial, but we don't have data to support a time delay.
Thank you.
Just
Yeah.
comment about the comment that was made two comments ago. With newer technologies of doing PGS and PGD, we actually do not see a lower success rate when we're transferring back PGS normal embryos. So success rates with PGS normal embryos now doing trophectoderm biopsies are close to 60 to 70%. So the earlier studies were doing day 3 biopsies, and that's what was published in the New England Journal, but we're no longer doing that.
Great, thanks so much.
Yeah, I lost a colleague in Lagos some 2 years now. I'm not sure the oncologist was aware that she could have chemotherapy at the second trimester. And seeing that right now, it's quite painful for me that she's no more, and we didn't optimize what was possible. And I also want to ask, because she was multiple gestation, is there any difference with what you can offer to women who have not singletons, like twins, triplets? Is it different from the regimen?
Well, I first want to say how sorry I am to hear about the loss of your colleague, and I think that it just it reinforces the need that we all have to talk about guidelines and to establish guidelines so that they're available throughout the world on how to manage cancer during pregnancy. That being said, I think that not being an OBGYN myself, what I understand about multiple pregnancies, twins, triplets, these are really protected high-risk pregnancies at baseline. So I think these are pregnancies for which a really close relationship with your high-risk OB is going to have to be truly optimized. And I would have to defer to my colleagues in high-risk OB and have a good relationship with them to help me. But we would plan to do the standard treatments I recommended, even in that setting. Thank you so much.
Thank you, Dr. Jeruss.